Hi, everyone. Welcome to today's Research America Alliance member meeting. I'm so glad you joined us. And as always, thank you so much to you and to your organizations for your ongoing partnership. Today, we have a special double feature Alliance member meeting. First, we'll hear from Joel White, who I'm sure a lot of you know. Joel is the Executive Director of the Health Innovation Alliance. And he's going to be discussing what's been happening in the digital health arena and also telemedicine. So as you all are aware, these have been critical in the COVID-19 response. And also they are, I don't think it's hyperbole to say, changing the face of health and clinical and other research going forward. So after Q&A, we're going to hear from Pete Kirkham, who we've had on several times. He is a consultant of Research America, the president of Red Maple Consulting, and Pete's going to provide a state of play on all the moving pieces on Capitol Hill, or at least the ones that we've been watching. There are too many probably to go through all of them. But as always, go ahead and type your questions into the Q&A box if you would, or in the chat, and we'll do our best to get to all of them during the Q&A portions of today's session. So with that, over to you, Joel.
Great, thanks, Ellie. Really appreciate it, and really happy to be here today and talking about what's happening in the digital health space with Congress and the administration. And I wanted to just kind of provide some context to start out, but the big point I want to make is that it would be wrong to think of digital health as just simply tools that we use on our phones or in the physician office or the hospital. These are really transformational ways to deliver higher value care. And that's what we need to keep in sight. We don't want to think of these as just widgets and things that we carry around in our pockets, but really the end goal to using these things is to get to a better value, lower cost, higher quality patient outcomes, and at the same time to facilitate research. And we'll talk a little bit about how these tools are actually working on the ground to do that. So you want to go ahead and get to the first slide. Just wanted to give some context again on the schedule. Sorry, some of these boxes are a little messed up. I guess it didn't translate in sending, but we're in a very busy period towards the end of the year here. I'm sure you've all been watching the back and forth negotiations around the budget bill, but a couple of transportation programs expire at the end of the week, the end of the weekend, related to infrastructure, and there's really a push on to kind of come to a deal around the budget bill to get the infrastructure bill possibly passed this week. I honestly think that's too heavy a lift. I'm not sure it happens. There might be a temporary extension. But then on December 3rd, the government lights will go off if Congress doesn't pass a continuing resolution, and we hit the debt limit again. And at the end of the year, we have a bunch of statutory provisions that are expiring: enhanced ACA subsidies, cost sharing subsidies, flexibility around dependent care FSAs, and the statutory provision around telehealth, high deductible health plans expires. But then January 1, a bunch of payment cuts come winging in the Medicare side, where hospitals will face about a 6% across the board cut in Medicare. On the physician side, about a 10% cut unless Congress does something to act. So we're expecting an end of the year package that would probably be tied to a continuing resolution to keep the lights on and the government running, but also some kind of legislation to address some of these expiring provisions and some of these bad things that are happening on the Medicare side. So what gets rolled into that package? We're not really sure, but one thing I do want to convey here is that the flexibilities around telehealth that have been created during the COVID pandemic kind of end with the public health emergency that was declared by first the Trump administration, now the Biden administration. That ends on January 17th of 2022. And I'll get into some of the telehealth flexibility and what I think is going to happen with that in a second, but you can go to the next slide. So the big things in front of Congress right now, the infrastructure package and the budget process. So on the infrastructure side, the big thing in digital health there is, a lot of money for infrastructure, but $65 billion for broadband. And that's the whole package is kind of offset with some health spending cuts. But the broadband really is an enabler. It's the pipes that carry the data, that facilitate some of the digital tools, particularly telehealth. And if you think about like video technologies and synchronous kind of office visits, particularly on the mental health side, that's really important that in those areas where you don't have broadband, it's really hard to do that type of telehealth. And so those subsidies will be would greatly expand the reach of telehealth across the country in areas that don't currently have high-speed broadband. And then the reconciliation package, obviously we've been back and forth on this for a number of months. I won't get into all those details, but the push is on. Top line number of 1.5 to 2 trillion, maybe more, maybe less. We don't know yet. That hasn't been agreed to. The policies haven't been agreed to yet. So hard to see how that all comes together in the short time frame that the Democrats have laid out. But there are a number of things in the reconciliation package related to coverage expansions, and important in those coverage expansions are digital tools that consumers use to help access care. So that will either come together or not. I know I'm going out on a limb there, probably by the end of the year, but we're waiting to see how that process plays out. You can go to the next slide. So just very quickly, what's in, what's out. I think the main point for this slide is that this package is getting smaller, not bigger, largely because we have we have an evenly divided Senate and a 3-vote majority in the House. But the goal here is to really expand Medicare, expand the ACA, expand Medicaid, and make those programs more affordable for the people who are enrolled in those programs. You go to the next slide. So just to get to broadband, again, this is part of the infrastructure package. You can see all the different provisions that are included in that $65 billion. The big thing to note here is that 47 billion of the 65 billion is to reimburse disproportionately affected populations and small businesses to subsidize their access to broadband. And then the remainder is kind of in all the other buckets, primarily for infrastructure and unique ways to fund broadband expansion, like through tax credits, bonds, spectrum auctions, et cetera. And again, that broadband is really the pipe that brings telehealth to people who don't currently have access to telehealth services, which means expanded care opportunities, particularly in rural areas, but also in urban areas. And if you look at any heat maps of major cities, Philadelphia is really fascinating. We have a lot of areas in Philadelphia in particular that lack access to broadband. So this is not a rural urban issue. This is kind of a across the country type issue. And the subsidies in that $65 billion go and target those communities in very specific ways. So it's really going to see an expansion of broadband around the country that will facilitate an expansion of these digital tools. So you can go to the next slide. And so when we talk about telehealth provisions, what are we actually talking about? The thing that most people have focused on has been the little thing over to the right around access. There's some archaic rules in the Medicare program that basically say you have to be in a rural area and you have to go to a doctor's office or a clinic or a hospital to get telehealth. And what we did when we had the public health emergency, we created flexibilities both in Congress and with the administration through their regulatory authority to eliminate those barriers. So now you can get telehealth in an urban setting, a suburban setting, and the rural settings. And you also can get it in your home or at a friend's home or a caregiver's home to be able to access telehealth through the Medicare program. And the commercial market has followed suit. Payers have kind of flexed up the ability to access telehealth. And the important thing here is that with that flexibility, what we're seeing is expanded access to services for people who are involved in clinical trials. I was talking a little bit earlier with Ellie about Department of Veterans Affairs has really leaned into this space and are providing access to clinical trial services and regular non-clinical trial related services for people enrolled in those trials. And that's really exciting because it's expanding participation in the clinical trials and accelerating some of the research that's being done. But these flexibilities go away when the public health emergency goes away. And what we're expecting when the January 17th public health emergency deadline comes and the public health emergency expires, the Biden administration will extend the public health emergency through the end of 2022. And that means all those telehealth flexibilities remain. And at some point in 2022, we expect Congress to statutorily expand the flexibilities so that they're no longer reliant on the public health emergency for those continued flexibilities. So what has been the result of this incredible flexibility that's been created? If you go to the next slide, we'll see it. Explosive. It's been, excuse me, absolutely explosive. If you start at the left and go to the right, about 3,500% increase in telehealth claims at the start of the pandemic, and it's begun to taper off and kind of come down to a more normal level. About 8% of all claims now are telehealth related. But we see within different patient populations really huge utilization. So mental health is about 90% of all claims. In cancer, it's less than 2%. That makes sense because it's hard to do chemo on a patient via telehealth, but for the mental health space, group outpatient settings and cognitive therapy and other things are easier to do via Zoom, Teams, and other video platforms. So these flexibilities and the payment changes have really accelerated the adoption of telehealth in all markets, across all markets. And our hope is that that growth that went like this, it's coming back down like this, it'll stable out at a more steady state of around 10% of all claims going forward. You can go to the next slide. In addition, in the reconciliation package, there's public health funding. I think the big takeaway here is that there's a major focus in the public health space to modernize the infrastructure and leverage data for real-time interoperable use. And that would then allow local and state public health offices to access data and to be able to respond on the ground much more quickly. And what we're seeing in this space in particular in digital tools is vaccine credentials and linking data that's in immunization registries and even EHRs to mobile tools that create QR codes that then allow people who are vaccinated or have been tested to access venues, whether they're restaurants or concerts or even airline for travel and things like that. And that really has becoming, it's got some negative connotations when the government does it, but there's Clear and IBM and a number of other tools that people are using now to gain access and to do things because they've done the right thing by getting vaccinated. But this acceleration and standardization of data, sharing of data, and use at the consumer level is really transforming how consumers are able to live during the COVID pandemic, and I suspect afterwards as well. You go to the next slide. In terms of, we talked about the pipes on broadband, but we didn't really talk about how that data goes through the pipes, and that's called interoperability. What's in play right now is really on the regulatory side. There are 4 primary rules that the administration, both Trump and Biden, have put out that really will facilitate access to data, and that data will facilitate new tools that will be created to empower consumers to engage in their care, empower providers to deliver that care, and allow payers to design programs that deliver higher value. And this is important because at the patient level, using digital tools to make participation in clinical trials easier will expand enrollment in clinical trials and hopefully make those clinical trials more meaningful. So it's the transparency and coverage. It's the 21st Century Cures Interoperability Rule. It's the HIPAA patient access rule and the CMS interoperability and patient access final rule. And the big one there is that fourth one. That interoperability rule basically says that health plans, have to provide consumers with their data through a third-party app of their choosing. And what we suspect is this is going to create a new middleware market where pharmacists and doctors and hospitals and academic medical centers will have apps that will allow consumers to request that information from plans. That information would then be provided to that provider who could then use it for clinical research, but also use the app to track real-world evidence and any kind of wearable data that the consumer might be using as part of that clinical trial. So real-time vital signs and some of the other exciting things that we see coming out, like the digital tattoos that are worn like Band-Aids that will automatically send data back to the provider to be able to track clinical trial data. So it's exciting. That rule will be finalized and enforced at the latest on January 1, 2023. And I think it's going to be a market changer. So it's really, I think the consumer revolution, the use of data, digital tools to access data to then facilitate better research and better care. And you can go to the next slide. So I'm not going to get into everything here. I think the big takeaway, sorry, we used a font that's hard to read, is that all of the data is moving through the pipes according to standards. And those standards are moving away from kind of sending stuff from point A to point B and really focusing more on API technology. And APIs basically allow software programs to interact. It tells those programs when the drawbridge is down and calls out a query and then gets the data back based on that query. And the future is APIs. And maybe folks have heard about FHIR standards. Those are getting integrated across all of these programs at the federal level to really facilitate data exchange across all the payers: Medicare, Medicaid, ACA, CHIP, et cetera. And that's really going to make data exchange a lot easier. And again, the data exchange made easier means that more data is available for trials and care improvement. Secondly, TEFCA is a national framework for exchange of information that will start to go live in Q1 of 2022. People will basically be able to access this national network, sign into it, and then be able to pull information from the network to be able to facilitate care and research. And then any discussion of interoperability would be incomplete without a discussion of privacy. We're not expecting Congress to act anytime soon on privacy, but this heightened interest in the digital health space is really being driven by consumer privacy concerns and those apps that are selling my data out the back door. Do I have a right to kind of stop that or control it or authorize it? Is really driving a lot of the privacy discussion. Those are around consumer apps, and healthcare is different. And so we want to make sure that as the consumer app privacy discussion moves forward, we recognize that healthcare is different and that research in particular shouldn't be harmed if we err too much on the side of locking down the data because of some things that may be happening on the consumer privacy side. And that's something that the FTC is working on, HHS is working on, Congress is working on. The Senate Commerce Committee has held numerous hearings on this. There's legislation on this, and we're working very hard to make sure that healthcare is carved out of that legislation so that when we modernize healthcare privacy laws, we're recognizing the difference there between your very sensitive healthcare records and the research that's kind of around that, and maybe the fact that you bought a sweater on J. Crew, and that's then being sold to a marketer to sell you additional products. And then I already talked about public health. The big thing there is this data modernization initiative, but we are also expecting this transformation in the immunization space to generate additional innovations around public health data. And we can see, last year there was a huge blow up over contact tracing and whether you would be automatically notified about whether you're within 6 feet of someone else who's been exposed to COVID or who has COVID just by carrying the phone in your wallet. And I think of that as like the tornado warning that we get, like when your phone starts going nuts. There was a huge backlash against that, but we're seeing private sector development in this area that would help us, one, warn people when they're maybe in a danger zone if they want to opt in, and two, if they have come within a specific geolocation of a person who's been infected, that they would then be notified and could take steps to either get tested or treated if they are infected as well. And that digital application, I think, isn't going to be an opt-in model versus the way it was done last year, which was we're just going to make this part of the operating system, and like it or not, we're going to use that data to to force you to be a part of this contact tracing program. So, but the future is data and the future is digital, and it's really exciting what's happening in terms of telehealth, mobile health applications, personalized medicine. It's all being driven by data. And I think that as we get to more standardized data and better interoperability, we're going to see a transformation on the digital health space, aided and embedded by these policy changes through regulations and in Congress. So that was a huge, fast overview. Hopefully I didn't take too much time, and I appreciate you guys letting me talk today. Thanks.
That was terrific. I have about a million questions. I'm going to ask a few really quickly. So this is just a definitional question. So telemedicine, telehealth, that's a subset of digital health, right? They're not, right? That's just in the lexicon. So you mentioned in the infrastructure bill, the broadband expansion, which for so many reasons seems like really good policy. It's going to be paid for by an across the board cut, real small. When you say sequester, that's an across the board cut against all government programs or health programs, or?
Yeah, it's health programs. This is a kind of a gimmick. Ellie, you were on the Hill a long time. We use these budget gimmicks. Basically, there's an existing 2% Medicare sequester that applies. And what they're doing is they just added it to the 10th year of the budget window.
Oh, okay.
So it's in 2031. The big pay for in the infrastructure bill is a partial repeal of what's called the rebate rule on drug pricing.
Drug pricing.
That generates a ton of money. And then there's a minor provision on unused product in single-use vials that they say is getting wasted, and we don't want to pay for waste. So we're going to recapture some of that. That's $3 billion.
And you mentioned the 2% Medicare sequester. That's an extension of BCA, right? Or was that part of BCA? That's just there was a tail that was just Medicare, right, Medicare focused.
Every time we get to a new fiscal year, they just move the period out another year.
Yeah.
And so it's really operating now almost like the old physician payment system work where you just kind of like, you get these cuts piling up. And so we do suspect Congress is going to waive the 4% budget law sequester plus the 2% Medicare sequester as we head into, those cuts apply January 1, 2022.
January.
So we suspect that's going to be in an end of the year package. The AHA, the AMA, all the specialty groups are lobbying very hard on this. There's been numerous letters from members of Congress saying we got to fix this.
So I think to me, one of the most important points you made was that the public health emergency, when that lifts, a lot of this telemedicine flexibility goes away. It becomes very restrictive again. You anticipate an extension of the public health emergency at least through 2022. Will it take you may have already said this, will it take statutory change or regulatory change to lock in those flexibilities so that you won't need public health emergencies?
Yeah, it's a statutory change. And because Congress is expecting the Biden administration to extend the public health emergency through 2022. So they don't feel an urgency to pass the statutory change in December. They're taking more time. So we're expecting before end of second quarter 2022, there will be a bill. and it'll extend these flexibilities for a period of time. We advocate permanent change because we think they're bad policies.
Right, right.
But the longer you do it, the more it costs, because the very smart people at the Congressional Budget Office say that telehealth is additive. It doesn't substitute for in-person visits.
Wow,
Is the first thing. Yeah, and it's a really kind of a crazy assumption because we have data from the pandemic that show, you don't get to 90% of all mental health visits are virtual now.
I was going to say, particularly mental health, that doesn't make much sense.
So we're actually doing a study with IQVIA to look at the claims data to show that there is a substitution here. It's not all additive, but the score of doing the 10 years or eliminating the policy altogether, I should say, is probably about $75 billion. And what we're hearing from the congressional committees is, that's really expensive. We can't do that. And we're scratching our heads going, we're talking about $2 trillion, $3 trillion bills. Like, this is small and the policy doesn't make sense, but we need to get that score down. We're doing this study to try and get that score down. But my suspicion is that they'll probably only do it for a max of 5 years. 3 years would be good. 1 year would be horrible, because if you just do it for a year, doctors, hospitals, venture capital, telehealth companies, plans won't put the capital into the market that they need in order to really make this, a massive reality. And what we've seen during the pandemic is exciting. I mean, people are using this for clinical trials. They're using it for their care. They don't want to go to the doctor's office because they might get infected, but they've got a chronic condition. They need treatment. Telehealth is the answer in many cases, not for all cases. Like I said, you can't do chemo remotely, or you shouldn't, I should say. But it's exciting, and we can't let this go away. Every member of Congress I talk to says we're never going back. And every staffer I talk to goes, it's really expensive.
It's really interesting. I think another dimension of this, and I hope no specialist is listening to me, is using your primary care more for the telemedicine visit, asking a series of questions that then you don't go see an orthopedist, an allergist to do, so there may be other ways you're actually saving money. And forgive me again to all the specialty community people out there. I've asked a lot of questions. I have more, but let me bring on Anna. Are you handling questions today?
Yep. Absolutely. Awesome. Yep. And just as a reminder to folks, please feel free to put your questions into the chat or the Q&A, and we will do our best to get to them. So Joel, one question that has come in: do you think data interoperability that respects privacy can normalize engagement in clinical research, both passively in terms of patient data, as well as actively, so volunteers in clinical trials? Because we hear a lot about how the progress of research is inhibited by systemic problems in attracting people to engage. Do you have any thoughts on that?
Yeah, I do. A lot of thoughts. So I do think interoperability will help. If you think about, someone who may be participating in a clinical trial who has either multiple conditions or a rare condition, they may have records spread out across multiple providers. Interoperability brings those records together for the clinician who's in the conducting the clinical trial. It makes it easier that way, and it makes it easier on the patient, right? Like, they don't have to wheel around boxes and boxes of their records in order to provide the documentation necessary to participate in the clinical trial. So that's the first issue. I think the second issue is that for folks who are maybe weary or leery of participating in a clinical trial, if we have solid privacy protections around the interoperability, that builds trust, and trust is critical to participating in a clinical trial. And so I think that we need to rethink that privacy framework to build the trust that, even though my data is flowing between multiple providers and maybe a health plan or, that's doing the clinical trial, it's all kind of protected, right? And that will help patients engage in that clinical trial. Right now, I think there's skepticism around that because of what's happening again on the consumer privacy side, where data is just kind of flying out the door. And one of the changes or the differences, this will show you how really old I am. I actually did some work on the fraud and abuse provisions in the HIPAA law back in '96, and then Ellie and I spent a couple of felt like 9,000 hours in a room negotiating over, a possible follow-on bill before the HHS regulation came out, and that was a very different time. I had hair, we didn't have smartphones. The iPhone hadn't been invented. It was 2001 when that rule came out.
Stop! You're aging me.
Wait, the smartphone didn't come out till 2007. I mean, so to say that was a different time is an understatement. Now we've had a cultural, societal, and technology transformation. People are more comfortable with the technology. They're skeptical about the data, but we've got an ability to encrypt and use technologies to better secure the data, protect it. And what we don't have is the policy layer, the privacy rules that have been updated to reflect these cultural, societal, and technological changes. And so we've got this 2001 framework applied to a 2021 world.
Brand new
And
world.
what that means is, without mentioning any companies, these big tech companies generally are not covered under HIPAA. And so if I'm using an app where I've got a PHI on it and they're not covered under either a business agreement or the HIPAA rule itself, that data can go flying out the back door. Well, that's not good, right? The rules should follow the data regardless of who's handling it. So, and that framework makes more sense than saying, well, you're a healthcare provider or a health plan or a clearinghouse, so these rules apply to you, but you're Google, Apple, I didn't mean to mention company names, but you're someone else, right? You're not one of those three things, but the rules don't apply to you over there. That erodes trust. That's hard for then a patient to want to say, well, I know my data is kind of flying around because I get these ads come up every time I go on LinkedIn or whatever. So why would I participate in a clinical trial because I've got cancer or HIV or something like that? Because, if I get standardized treatment, maybe my condition won't be known, or I've got a sensitive mental health problem or something like that. So it's a real issue. We can fix, it's easier to fix the interoperability than the privacy. We need to do both.
Both. Excellent. I don't know, let's see, timing was, do you have time for one more question, Joel?
Sure.
Anna, do you have one more?
Yep.
I thought
yes,
there was
you. Yeah, so Joel, as a last question, we've heard that reps Upton and DeGette are going to be releasing their Cures 2.0 legislation in the coming weeks. Are you expecting any digital health or telehealth or telemedicine provisions to be included in that?
Yeah, I was talking to Congressman Upton 2-3 weeks ago, and we do expect some provisions in there. I'm not sure they've settled on the universe of the things that they're doing. We weighed in, we sent them a letter and said, you ought to include everything. We're greedy that way. But I think that if you talk to either Upton or DeGette, they'll both tell you their number one priority is ARPA-H. So do those other things happen alongside ARPA-H? It's hard to see in this environment how that does happen with the big bills that are going on and kind of the personal fights and kind of animosity, and we're getting around the corner. I do know that there's a whole slew of opioid bills that may include some data and digital tool technology provisions. There's maternal health that include a lot of, that includes some digital tools. So the maternal health stuff, obviously we've got a crisis in this country.
Yeah.
I see that more likely to move than maybe, a smattering of provisions in 21st century cures. But I think the more members that are including these types of changes in their bills, the better, because there's a recognition that, kind of this is the future. And many of our programs don't incorporate technology in a way that maybe private payers do. The one last thing I would mention, sorry to add on to the time here, but I didn't even talk about AI. And AI is huge. I think that it's slowly getting ingrained through the contracting process at the federal government. I think in Congress, a lot of folks have focused on bias in the algorithms and facial recognition technology. And I think that those are legitimate concerns. But if we ignore AI and what AI can do to help facilitate and spot patterns in the data and the research, we will have lost out. So we don't want a trade-off that says we're going to address bias and sacrifice research.
We need to do both.
We need to do both. And,
Yeah.
and that's going to be a balance. And I think a lot of members on the Hill don't really know what AI is or machine learning is. And so we need to get up there and educate and quite frankly, evangelize and make sure that people know we don't have to sacrifice research to address bias. We can do both.
That's awesome. So very importantly, finally, could you ask my drugstore to stop making me sign every time I get a prescription because of HIPAA?
Yes, and you know what else we need to do? We need to make a standardized national electronic authorization for research somewhere in a database so that if a person opts in and says, I want my data used for research, all a researcher has to do is ping that database and say, yep, I've got the authorization, and boom, you're done. But we need to do away with those HIPAA forms. No one even reads them anymore. It's just a joke. Yeah.
No, but I love this research idea, and I have a feeling our CEO, Mary Willie, will adore it. Well, thank you, sir. I'll be in touch with the other 9,000 questions I have.
It's been my pleasure. I really appreciate it.
Thank you so much for joining us, Joel.
All right.
Okay.
Take care.
Pete, there you are.
Hi ho, how are you?
Good. So, you have a very easy assignment. What's going on Capitol Hill?
Well, yeah, everything and nothing. I thought maybe what I do is let me answer that question, but let me preface it by praising Joel and just I think his presentation was a good reminder of why we all came to town. We all got involved in public policy, and that's to change things for the better in this country. And what Joel was talking about is a textbook definition, textbook example of what you do with long-term engagement on Capitol Hill and with the various administrations. I learned when I first came to Capitol Hill, I've always worked for workhorses, not show horses, but all of them have said, I'd rather have part of something than all of nothing. Yeah, they always are willing to take a win, no matter how small, how little, and come back again and get more. And again, long-term engagement. And by way of analogy, I remember reading in Peter Thiel's book, 0 to 1, I think one of the things he talked about with the promises about the internet, he said, over a 10-year period, the promises are ridiculous. We can never, we overstate what's possible. But he said, over 20 to 30 years, we underestimate things. I think the same thing applies to legislation. The little pieces of things that we're working on to get into the ARPA-H bill or the reconciliation bill, even if we don't get everything we want, we get something. You think about what transformed this country. We all know about the Civil Rights Act, the Interstate Highway Act, but you could argue that since the Civil Rights Act, one of the most important pieces of legislation was a little provision stuck in the 1978 Tax Act, which was defined contribution pension plans. Changed everything. Who had a clue? Nobody had any idea. So all that came to mind as Joel was talking about all the long work that you were involved in, Ellie, Joel was involved in, so many other people, and getting all of this information stuff off the ground, putting systems in place, putting permissions in place. Yeah. And then when the technology was there, lo and behold, look what happened. So that's the good news preface to say
that's right.
To now get,
keep at it.
Let's now get down in the ditch of congressional politics and the mud. So let's start with reconciliation and infrastructure. There was a great quote in Politico this morning in Politico's playbook, which describes where we are with the reconciliation. It was Congressman Brendan Boyle, who's a Democrat from Pennsylvania. He said, quote, "We're just missing two things, what exactly is going to be in the bill and how we're going to pay for it. Other than that, we're good to go, which I think sums it up. And so where are we? I think we're where all of us who are congressional veterans or who've been around the public policy process knew we were going to be in February, which is Congress operates on deadlines. There's actually only two deadlines that matter in Congress: Christmas of the off year and January 3rd of the on year. Those are the two deadlines that matter. And so we are, for all of the breathless news coverage about the Biden administration and make or break moments and going to Glasgow, we are in the normal congressional schedule. If you go back and look at the reconciliation bills from 30 years ago with Ronald Reagan, same thing, nothing's changed. It just takes time to get things done. And members and interest groups and the public all have to sort of be brought around to what reality is. And you don't know what reality is if the speaker, the president, the majority leader in the Senate, they don't know what reality is till we get to now and figure out what people are willing to vote for. And they're just now figuring that out. So do I believe there's going to be a reconciliation bill? Yes, I do. Is it going to be 1.5 trillion to 1.75 trillion? Yeah, that sounds about right. And that's what almost everybody was predicting in February, if we remember. And is that an enormous win for the president and the speaker and Mr. Schumer? Of course it is. I mean, that's you have $1 trillion+ of the pandemic funding in March. You have this enormous bipartisan infrastructure bill of another $1 trillion that's coming down the pipe with all the great things that Joel talked about. And now you're going to have another $1.5 trillion of sweeping policy changes, maybe not as much as people wanted. But yes, those are enormous wins. And I honestly believe they're going to happen. As for timing, I'm not holding my breath yet. I don't think we're there yet. We got a ways to go. All the focus is on Mr. Manchin and Ms. Sinema, but certainly they are stalking horses for other members of the Senate who don't necessarily want to take some of these votes either. So there's a lot of hand-holding that's got to go on, a lot of egos on all across the spectrum of the Democratic Party that need to be assuaged. But I would not bet against the speaker. The speaker she knows what she's doing. She's been down this road before, and I would bet on a bill. Reasonable to assume maybe by Thanksgiving. I think that's possible. And but that question gets to everything else that's going to happen for the rest of the year. The reconciliation is sucking the oxygen out of every room in the Capitol. There's nothing else that's really happening right now. So with that, I'll stop on reconciliation. I'm happy to go on to appropriations, China competitiveness, wherever you'd like to go.
Yeah, no, I think what you said is really important, because what we know is that, particularly on the Senate side, in terms of things like pandemic preparedness and ARPA-H, that reconciliation has to be done before those become real. We see any paper or anything like that. And it also speaks to the appropriations process. Now, we did a sign-on letter, and thanks to all of you out there, 200+ organizational signatories saying, don't wait. There was a method to that madness. The chances that that Congress was going to be able to do something about the appropriations package before December 2 were, minute. However, the more we have this drumbeat, what we're trying to avoid, and I'd love for you to give us a sense of timing, Pete, is another delay, then another delay. So what's your crystal ball saying now about the appropriations process?
If you forced me to lay down a nickel on and bet it on what I think is going to happen, I think it gets kicked to next year. And I think we're looking at February, March. I hate to be a pessimist, but as we all know, the appropriators, once the appropriators are given a number, they can be done in a week. Yeah. they know how to get this stuff done, and they're happy to get moving. But we haven't even really started the negotiations. A key point to remember here is everything that's happened, with the exception of the infrastructure bill this year, has been a story about congressional Democrats and the politics within the Democratic caucus in the House and the Senate. For appropriations, Senator McConnell, Senate Republicans and House Republicans have a vote, particularly in the Senate. You cannot get appropriations done without them. So there's going to have to be a deal. The overall budget numbers that the House passed their appropriations bills at on the domestic side are going to come down, and the defense numbers are going to go up. We have done this dance for 40 years. We do this every single year. When Republicans are in charge, defense comes down and domestic goes up. When Democrats are in charge, the reverse happens. And so that's not going to start, as you said, Ellie, until reconciliation gets done. Reconciliation's on the president's desk, infrastructure's on the president's desk. There are hosannas in the New York Times, the Washington Post, and signing ceremonies, all that stuff. Everybody goes home for a weekend, and then we're into appropriations. And so Senator McConnell, Senator Schumer, Speaker Pelosi, Leader McCarthy, and the president have to agree on a number, on an overall number. And that's not going to come quickly. That's going to take time. And hopefully it can get done in December. Hopefully it's going to be one of these Christmas Eve things, and then we're done and we start fresh. But the people that I talk to, these are Democratic cardinals and ranking Republicans on the subcommittees and key staff and leadership and elsewhere. They all say, well, I'd like to get it done, but I don't see it. So we'll see. Keep hope alive. And to your point, keep pushing. The drumbeat has to be there to remind people how important it is. Will it get done? Yes, it will get done, because if the congressional Democrats and the Biden administration don't want to operate under Donald Trump's budget, and that's what a continuing resolution is. A year-long CR is Donald Trump's budget again. So they don't want that to happen, and I don't think it will happen.
So that's interesting. Does that speak to the defense spending? Because for me, one of the pressures, and I believe that the patient community, the research community has a role in pushing this. But I would also guess that we would want a new defense budget with things like what's been happening in China and that kind of thing. But so is the defense community pushing for a wrap up of the appropriations process? It's high. The budget is higher, will be higher, one way or the other.
That's right. That's right. And the defense authorization process. Yes. Both those things are hanging out there. Both are important to that community and to many people on Capitol Hill on both sides of the aisle. And but again, we come back to delve into the weeds. We need a 302A. Section 302A of the Congressional Budget Act is
that top line number.
Here's the number. Here's that top line number. And those 5 individuals that I mentioned, the leaders and the president, have to agree on that number. After that happens, it all can flow and the appropriators can be done in a week or 10 days. But you're exactly right.
That's interesting, because to me, it bears on pandemic preparedness and everything else. I mean, not just to me.
That's right. That's right.
So
there's lots of pressures out there.
Yeah. And do you think those negotiations won't start until after the infrastructure bill passes also?
I think it's reconciliation. I think the infrastructure bill passes in the blink of an eye as soon as reconciliation is done. I don't think there's any issue about that. So it's all reconciliation all the time right now.
So Pete, a question about advocacy and lobbying. You're on the Hill right now more than I am, and is most of it still Zoom, or are you pounding the pavement more these days?
I'm pounding the pavement more. I'm beaming to you from the ceremonial office of another client of mine. They let me use their townhouse, and part of it's just because I got tired of sitting on the couch and wondering whether I was going to sit in this armchair or that armchair for today's work. But there are increasingly people that are doing that. So there's more of a group up here, but getting meetings, in-person meetings in the buildings is still exceedingly hard. It's almost all Zoom unless it's a member meeting. Member meetings are difficult to get. And I think most folks are probably familiar with how difficult it is to get meetings in the Capitol on any circumstance. You have to be on a list, you have to go through security. You have to do that for all the House and Senate office buildings. And that's not going to change for a while. It might change after the first of the year. So it's all virtual. There aren't a lot of meetings to get in person.
I will say that in what I've been noticing is that the Zoom meetings, the one-on-one Zoom meetings with offices, or if we bring our alliance members, are actually very successful. I think that the staff feel they have more control over the amount of time. And I think what is difficult are Hill briefings. You can't offer that lunch,
That's right.
I think that's been the harder piece of things with advocacy. So what have we missed? So pandemic preparedness and ARPA-H. We know that Congresswoman Eshoo has a bill that she's put out.
All right.
And that, as we heard from Joel, we know Congressman Upton and Congresswoman DeGette also plan to put out legislation that features prominently ARPA-H.
That's right. That's right. And we know the Senate Help folks are looking at things in great detail. And it's good that we got so many key members that are interested in this, are starting to put their ideas onto paper. Things are starting to come out. This is a good thing. The China competitiveness bill is another one. And on all these bills, we quote the ranking member of the Science Committee, Frank Lucas, congressman from Oklahoma. I talked to him about the time the China competitiveness bill passed the Senate, and asked him, well, what do you think the timeline is? And he said, well, I've been around this place for 30 years. And bills like this, and we can include a Cures 2.0 or an ARPA-H or other things. Bills like the China competitiveness bill, they need the slipstream of the big giant package. When negotiations for reconciliation finally get to the point where things are really moving, then people know there's a big package coming. There's going to be a wake that carries other things along with it, and negotiations just start on everything else. And there's a famous phrase that applies to lobbying that I think also applies to legislating, which is lobbying. 95% of lobbying is standing around.
Yeah.
It's just standing in the right place. Well, legislating is the same way. It's just getting ready, being ready, and then that moment strikes. So I think you're going to see a bunch of stuff move. When reconciliation finally happens, you're going to see a bunch of stuff moving its way.
Moving along. That's great.
Yeah.
I've co-opted a lot of your time. The one other thing I just wanted to mention is that, particularly on the Senate side right now, the House has gone farther on ARPA-H than the Senate. I think that Chair Murray and Ranking Member Burr would say that that's absolutely true.
Yeah.
On the Senate side, both Senator Murray and Senator Burr, who are working very closely together, are open to suggestions about pandemic preparedness, about ARPA-H. They're looking for input. So I encourage you all, if you have input to give, go ahead and get in there and do it. And Anna, do we have any questions? I think we've already gone over time, but any questions for us?
Yes, we have one question that's come in. Pete, what do you think is the likelihood of a 2-year budget cap deal as part of completing FY22 appropriations?
Wouldn't that be nice? And I actually think it's possible. So part of what's going on here, and again, both parties do this depending on who's in the minority, but delay is the minority's friend. Just kick the can down the road, and hope for the political dynamic to change. And so it's in Senator McConnell's best interest to delay things as much as possible. But at a certain point, he also knows, because he's a deal maker, just like the Speaker is, just like Leader Schumer is, that things have to get done, and you got to put the structure in place. So my instinct is that it is a better than even chance that we get a 2-year deal, because who wants to go through this after the election? So we will go through the pain. Nothing will get enacted till after. So FY22 gets enacted at some point. Maybe it's December, maybe it's February or March. And then FY23, it's not going to get enacted till after the election anyways. So why not just have the deal in place? There's a lot of logic to that.
That makes a lot of sense. Anna, is there another question in the Q&A, or did we just cover that one?
We are full up in the Q&A, Ellie, but we can ask one final wrap-up question, Pete, with your crystal ball. Since next year is an election year, is there any kind of point where you foresee gridlock? That that's it. Everyone switches gears to focus on the midterms. Any thoughts there?
Aren't we there yet? Yeah. I mean, certainly it's an old saw that big things. Well, back up. We're about to find out if congressional Democrats in the House are a disciplined majority. I mean, I'm an old House Republican guy. House Republicans have not been a disciplined majority since 2006. We're going to find out if congressional Democrats are a disciplined majority. I think they are.
With
And
reconciliation.
if that's the case, yeah, with reconciliation. And if they can get that done, they can get other things done up through August. Maybe there's some stuff that gets done in September when they come back next year. But end of July, 1st of August is roughly the time frame. And there's always little bipartisan things that go along under the radar screen along the lines of what Joel was talking about. A lot of that's just been bipartisan. Things get stuck on here, stuck on there, pass on suspension. That stuff always happens. But I think the key thing is, are the Democrats going to stick together? And if they do, well, you might see some more stuff next year. I think it's very possible.
Terrific. Well, an optimistic way of ending today's meeting. Well, I know we're going to keep you in suspense. I'm sure none of you are going to sleep about our next Alliance meetings. We have some teed up. We're just finalizing some details, but I promise you they'll be good. And Pete, I want to thank you as always for being our Hill guru. And again, thanks to all of you. If anyone on this webinar happens not to be a Research America member, your organization, please shoot me an email, or you can shoot Katie an email from our team, and let's talk. We'd love to have you join us. So with that, let's call it a wrap. Thanks for seeing us. Well, thanks for being with us.
Bye, everybody.
Bye, everybody.